Yes, thank you very much for that nice introduction, and thank you for the invitation to speak here. I think we'd all agree, fabulous conference so far, and that the discussions are only getting more heated as we go along, which is always great to see. So indeed, I'm going to be talking about the significance of the solid component of lung nodules. But firstly, because we are such a diverse international group here, I wanted to start with the terminology. So when we talk about solid nodules, we talk about a nodule that's completely obscure in the lung parenchyma. Whereas when we talk about a part solid nodule, it has a solid component, one or more, that completely obscures the lung parenchyma, but that it still has a non-solid component to it. And when we talk about non-solid nodules, none of the lung parenchyma is obscured. But what we see when we're looking through the literature is that actually part solid and non-solid are quite commonly referred to as subsolid, grouped together. And actually there's many different terms which are being used to describe these nodules. So you hear about ground glass opacities, shortened to GGOs. Then you have mixed GGOs, part solid GGNs, ground glass nodules, mixed nodules. There's many different terms that are being used, and I think this is something we can focus on going forward, is trying to standardize this terminology so that we're all on the same page. So I wanted to look at the frequency of these nodules, how often they occur, and how often one of these nodules would be could be a malignancy. So we took here the data from the I-ELCAP, and if you look as expected, you see that the solid nodules are the most common, both at baseline and at annual. But when you look at the malignancy risk, you see that the malignancy risk is higher in the part solid and the non-solid, but that these nodules are always stage 1, and quite oftenly the adenocarcinomas. So the part solid and the non-solid are associated with higher rates of malignancy, but then they're detected at stage 1. And as Professor I-ELCAP mentioned yesterday, that baseline CT, that you start filtering out the stage 1s if you're lucky to catch them at baseline, or sometimes you have the stage 4s and everything in between. So actually the real art of the screening, if we can get the participants to come back, is the follow-up of the nodules. So either a short-term follow-up or an annual screen or a biannual screen. So if we look at the growth patterns of these nodules over time, I take again the paper from my colleague, Bei Yang, you see that the solid nodules, they grow the fastest, which is what we know. And then the part solid and the non-solid, they grow slower. And so then you can infer that a longer follow-up interval, so as we've just heard, an annual or a biannual, could be an option for these nodules. But what you see is that the volume doubling time is actually quite heterogeneous, and this is then quite often representative of the dynamic changes of that solid component of the nodule. So the challenge then becomes, and also as we heard in the case discussion yesterday, is when to really refer these for diagnostic workup and when to treat them. You want to avoid doing surgeries to remove cases which are actually not malignant. So that's where the significance of the solid component comes in, and this is related to the pathology. So you will see quite often that that solid component, shown in the literature, is related to that invasive part of the from the pathology, and then the non-solid component, that's related to the lipidic part of the pathology. And this has now been incorporated into the IASLC staging manual. So they now take into account what's seen on the CT and how big that solid component of the nodule is. So if we look at the survival dependent on the lipidic part of a nodule, from this study, it also uses I-ELCAP data. You see that the larger the lipidic part of the component, then the better the survival is for the individual. And a more recent study looked at the opposite way around. So can you use the solid components of the nodule as a prognostic indicator if you compare it to taking the whole nodule's volume? This was in adenocarcinomas which were manifesting as part solid lesions. And what they saw is that the volume doubling time of the solid component The 200-day threshold was the only indicator significantly associated with both recurrence-free survival and the overall survival. Dr. Yip published a paper in 2017, a review where she looked at the solid components of part solid nodules and the disease-free survival and overall survival associated with the size of the solid component. And if you take the threshold as 80% for determining the part solid nodule, you see that if the solid component is less than that, then the disease-free survival and the overall survival is very high. So the lowest here is 94.7. It can be up to 100% survival if that solid component is less than 80%. Whereas if you look at the other studies which looked at which had a part solid component above the 80%, you see that there is then the disease-free survival and the overall survival starts to decrease. So as low as 48%, 43% there, but actually that median is still quite high for these cases. But what was actually really nice about this paper is it highlighted the points going forward where we need to pay attention to. This is something what we can be working on as a group. And what you see is that there's quite imprecise definitions of part solid nodules. When measuring the solid component and to determine whether a nodule is part solid or not, different measurement approaches are used. So some use the solid component divided by the whole volume. Some use it using different window settings of the CT scan. And different studies use different cutoffs, and some say, for example, 80% and above, you should say it's a solid nodule with a halo around it. If it's below that, you can classify it as a part solid, but some use a threshold as 50%, for example. So to me, this screams we need standardization. So I have a couple of examples now, one from Foreign Longer and one from the UKLS, where we can look at if you alter from a solid nodule to a part solid nodule and use a different algorithm, you can end up with a different result. So at the top here, you see the classification as a solid nodule, and you see that from the baseline to the 1 year, 1 year to the 2 year, the VDT was negative throughout. Whereas if you take the solid component, but it's classified as a part solid nodule, the solid component is measured smaller. And from baseline to 1 year, it's negative. So in agreement if you take the solid. But when you look at the 1 year to the 2 year, actually the volume doubling time all of a sudden becomes less than 400 days, which we would classify as a positive. So between the solid measurements and then the solid component measurement, you end up with a different nodule type classification, different measurement, and then a different overall classification for the participant. And an example here from the UKLS, the nice thing about the UKLS is that we had the histological results, so we know that this is a stage 1 adenocarcinoma. This case is taken from our AI study, which we recently published. So here you see 2 readers' results and then the AI at the bottom. So you see that reader 1 classified it as a solid nodule. From baseline to 3 months to 12 months, they had a volume doubling time which was above 600 days, so it was a negative. So this participant continued to be followed up annually, according to that reading. If you take reader 2, again, they classified it as a solid nodule. Between baseline and 3 months, they say that its volume doubling time is less than 400 days, so technically that would have been a positive. Then between 3 months and follow-up, it becomes a volume doubling time, which would be negative. And AI said, no, actually, wait, this is a part solid nodule with a solid component that then from baseline to 3 months is less than 400, so positive, and from 3 months to 12 months, still positive, still growing rapidly. So you can argue in this case that the AI actually was the one that classified this nodule correctly, as this turned out to be the adenocarcinoma. So to summarize what I've just mentioned, I think it's important that going forward, we really standardize the terminology that we're using. We have solid nodules, we have part solid nodules, and we have non-solid nodules. The solid component is the part that really tells us something about the invasiveness of the lung cancer. So it gives us more information as to the growth of the invasive part. At least really a minimum of one follow-up is needed. That could be a short-term or an annual, but this will give us an idea about the change in the solid component, and we can see then what, if it does grow, then is this really a really true solid nodule, or was this a part solid nodule? And the methods we've seen, they vary greatly. So we need to be consistent in the methods that we're using to measure them and to classify the nodules. We need to form a consensus on what is the best way to do this. Be consistent also over the follow-ups that are performed. And then also, we've heard a lot about AI so far, but AI could be the one that helps us here to standardize these measurements over time, especially for these smaller nodules, where it's just quite difficult with the human eye to determine which part is the solid, which part is the part solid. AI can really help us there. And with that, I would like to thank you for your attention.
Thank you. That was a wonderful discussion. And I just, when we ended our first screening program, we started sending out all the reports to the participants each time. And one lady came back to me, because we used to call them ground glass nodules. She said she went into her kitchen, she threw out everything because she thought there was ground glass in the food that she was eating. That's how she got the ground glass nodule. So that, I said, we have to come up with different terminology. We spent about a year discussing this among us to come up with the solid, part solid, non-solid. And I loved, Harriet, your summary of this. Thank you.
Yeah, excellent talk. I was intrigued because we heard the talk by Mario, who says AI is not really ready to measure subsolid nodules. And you just alluded to that AI may can help. Could you discuss that a little bit for us? And I'm actually looking also at the mean density of the nodule over time. Is this a factor for you as well when you decide whether a nodule becomes denser or a solid part is increasing?
Yeah, so for the first point of whether AI is ready, I would agree with Mario that for the non-solid nodules, we don't use the volume. For the solid component, though, of the part solid nodules, we really do. And we see that if you change that manually, you end up with a much different reading. So probably then it comes to the point where you actually shouldn't start adjusting with what the AI says, as long as you've got a good functioning AI software. Of course, that varies depending on the software.
And then allude us to how your definition is cut off between the ground glass, component and the solid component, non-solid component and the solid component. Could you allude us where you put your threshold? Because many people have different thresholds in their mind. What do you use?
Exactly. That's a very good question. So the software, if I remember correctly, was minus 188 Hounsfield units. But again, this differs greatly. So if I actually try to look back on this, well, what is the range then of what we're using? That's very difficult to find because it's very difficult for the people to determine how where they want to set that, and they also relate that then to the other tissue of that patient themselves or that participant themselves. So that's a very good question, and I think that's something also that we need to be really standardizing. Where are we setting that threshold, and can we say that it's going to be the same for then every individual going forward?
Well, thank you very much, Harriet, and thank all of our speakers. They were really most informative and food for discussion for the next panel discussion. So thank you very much.